Good morning, everybody. Assalamu alaikum. Thank you very much for being here in time. It's my pleasure to start the day, and I would like really to sort of take you through some of the issues related to Helicobacter pylori management. I think I'm not really going to take you through, the classical way of how to approach the disease and how to diagnose it and treat it. But instead, really, I'm going to raise more questions than actually giving answers. And we will really look at critically examining what we're doing at the moment and looking at what shall we do in terms of our current practice here in United Arab Emirates in particular. And knowing the best practice that could be applied, what are the challenges and what are the difficulties of actually doing that locally, and again the hidden dangers and the associated possible long-term complications out of that. And I think then we're going to raise and discuss sort of an arguable theme at the moment, where you test and treat for H. pylori gastritis and some of the new recommendations. I don't think anybody can actually speak about H. pylori gastritis without referring to this man, Murray Marshall, who is still alive and practicing in Australia. He was offered the Nobel Prize, of course, a few years ago. But I think if there is anything to be given more than the Nobel Prize, I think this man deserves that kind of prize, really, not just for establishing the link between H. pylori infection and the peptic ulcer and the cancer, but I think for more to come. Yeah, there will be more to come out of his discovery. And I think the senior guys here can always remember the time when, the recurrent peptic ulcer disease was treated with really major surgery, partial gastrostomy and selective vagotomy and the associated complications out of that. And just imagine all that has been replaced by just 2 weeks course of antibiotics. So yes, he deserves more. And that is the organism we are going to speak about. On the gym sustain, that is how it looks like. So the hematoxylin and eosin, and on the gym sustain, that is how it looks like there. And from what you can see there, the organism is living in the mucus layer, just above the mucosa. It does not really go into the mucosa. It is there. The important fact to remember is actually it's an infection there, right? It is never there without a problem, even if it doesn't cause an actual symptoms. So harboring the infection there, I don't think it is something which you can ignore. Perhaps, at the current recommendations, I think we might be a bit lax. But I think evidence is being built up that says, well, no, you cannot really ignore it. And I think that is really a principle which I would like to put through. The rationales of treating various diseases nowadays is treat to target, isn't it? With IBD, with eosinophilic esophagitis, we dig deep into ensuring that there's no inflammation, at histological level. Yet at the moment, what we are told to do is actually, no, treat only if there is a problem. Not just say even problem, only if there is peptic ulcer disease, and you have to confirm it. And that is an issue which we're going to actually really question, perhaps. So that is the organism, right? And what I want you to actually remember out of its various factors, the virulence factors. What makes one particular organism more serious than the other? There are different parts of it. And things for you to remember is the vacuolating cytotoxic antigen there, and the cytotoxic associated antigen. Right? These are among the various virulence factors. These are the most important ones and proven to be associated with high risk of developing peptic ulcer disease and high risk of developing carcinoma of the stomach. On top of that, this gene here, duodenal ulcer promoting gene as well. Now, if we were to actually put that in context of what is actually going on here in United Arab Emirates, unfortunately, the evidence is weak, but Al-Farsi from military hospital, from Zayed military hospital, did some work on this. And they looked at perhaps not a big number, 55, and they found 55 of the isolated Helicobacter pylori, they were actually positive for the vacuolating cytotoxic, or the vacuolating cytotoxic antigen. 3/4 of them. Not just that, even the cytotoxic associated antigen, 75 of them, right? Both of them, 2/3. Yeah, small number of patients. That is the evidence we've got. Serious one. It can cause problem. That is the nature of the H. pylori we've got locally here. We cannot ignore. Perhaps, yeah, we need more evidence to support it, but that is what is available. So important fact to keep in mind. Another sort of not published, but basically was an MSc thesis between United Arab Emirates University and Zayed Military Hospital. Dr. Tayari, again, and another 26 patients, isolates using the PCR gene there, cytotoxic associated antigen positive. 2/3 as well. So it's the kind of bacteria we've got is actually a virulent one. It can promote peptic ulcer disease. It can promote carcinoma stomach. How common? I think the bottom line is fairly common. Yeah, among the MENA region, 2/3. But the data is variable. From sort of 3/4 and various ones. Now, the interesting part here, 40%, less than 0.5%. Is that true? I don't think you can accept it, knowing that almost 70%, 50% here is only 40%. That is questionable. I believe it is more than that. Because that figure came out of just some blood donors, and then they found 41% in general and 55% among males. So basically fairly common, and we cannot ignore that. 3/4 of people are actually infected among adults. Worldwide, as you can see the figure, it's everywhere. Sort of in Eastern Europe, in South America, but worldwide, that is the fact. More than half of the worldwide population are infected with H. pylori, very high incidence. Now, this points to the importance of testing the regional parts. Even within the same country, you cannot really sort of extrapolate the results of one area to the rest of it. You have to, be so careful, minute, and detailed in checking. Particularly if the composition of the community is different, where there is, immigrants, and that applies to United Arab Emirates. 2/3 of the population is actually out of the Emirates. They come from outside. Here, see, again, the figures are different, even sort of in close by areas. So you have to actually not just identify the prevalence among the different countries. Within the country itself, you may need to identify the prevalence among the different groups and the different areas. Another important fact points towards that this organism is contracted during childhood. And as you get older, the prevalence increases, say from 20% at 3 years, and after 10 years, it goes up to 60%. So acquisition of the organism occurs during childhood. And if you were to sort of target in a particular group to eradicate the infection, to sort of apply any kind of improving the standards and so forth, you have to look at early childhood, not late, after the development of complications. So, why do we bother? Because it does cause some problems. Although most of the patients are actually asymptomatic, some of them develop serious disease, peptic ulcer and carcinoma. And these are the figures. Yes. So who is going to develop what? If the infection is mainly antral, you're more likely to develop peptic ulcer disease, the gastrin hypersecretion of the acid. But if the infection is pan-gastric, all over the stomach, you're more likely to go into the long-term complications of atrophic gastritis, the metaplasia and dysplasia and carcinoma. But the fact is, once the patient is at the sort of the atrophy stage, that might be a bit too late to do much about it. And that is why, because if you wanted to target something, target it early on. So here is the long life risk. I'm sure, unfortunately, among ourselves here, say 50% of us are infected with H. pylori gastritis. Some of us are gonna develop gastric carcinoma out of this. Perhaps some will have peptic ulcer disease, and you have to think about that, right? So the lung, by the way, officially classified as class 1 carcinogen, no doubt about it. And I will show you some evidence behind that. So now 90% of gastric carcinoma, the adenocarcinoma in particular, is H. pylori related, 90%, almost all. But the likely risk is actually 3%. If you've got H. pylori infection, there's 3% chance for you to develop gastric carcinoma. But if there is a gastric carcinoma, 90% comes out of H. pylori infection. While the mucosa-associated lymphoid tissue lymphoma is less than 1 in 10,000. High risk. You cannot ignore it. I think we have to understand that most of the patients are asymptomatic, but those who develop symptoms, they're not actually ignorable. Okay. Now, you need to know that in the Emirates, gastric cancer is the second most common one. The second most common cancer reported at some stage is gastric carcinoma. And that is an important fact to remember. Worldwide, is the sixth mortality is the second. 10% risk of duodenal ulcer. So here is the some review papers, sort of systemic review between these 8 years. They came with the conclusion that gastric cancer is second most common among Emiratis males. Very common. It needs attention. While there is a Shamsi recently, or much more recently, just last year, came up with the list of the 10 most common cancers in the United Arab Emirates. For some reason, gastric carcinoma was not one of them. Both actually refer to national cancer registers. So that needs further clarification. Things are not really clear here. Okay, well, worldwide, I think we know that Japan, China, and the area there are much more infected with these organisms with high rate of gastric cancer. Now, in China, in Japan, they are promoting population-based eradications. And they have, over the last 40 years, from the 70s, this is the infection rate, the prevalence. 75, 3/4, less down by 20%, less down by 20%. Their children is currently just about 5% of them are infected. The infection rate is getting lower. Perhaps this applies to another parts of the world by the improvement of hygiene and so forth. So the infection rate is getting less in areas where mass eradication has been applied. In China, they compare the incidence of H. pylori infection among counties with high rate of gastric cancer compared to counties with low rate of gastric cancer. High rate of gastric cancer, high rate of H. pylori infection. Low rate of gastric cancer, low rate of H. pylori infection. There is the link. In Europe as well, there is a decreased prevalence of both H. pylori infection and gastric cancer. HWO sort of map of where the highest incidence of gastric cancers in dark blue and associated with high prevalence of gastric, the H. pylori infection. There is a link. Wherever there is a high rate of infection, there is a high rate of incidence of gastric cancer. Well, here is a clever study. Say, observation over 26 years. They randomized patients into infected patients with H. pylori, treated, non-treated. Fairly good number, 1,600. 26 years of observation, endoscopic on a regular basis. Look at the difference there. Overall, 43% reduction in the chances of developing gastric cancer. And that is even much higher if, to start with, you did not have a pre-malignant predisposition, 63%. So if we were to treat you with anti-H. pylori eradication regime, you get less chance of developing gastric cancer. And a fact difficult to ignore, right? In America there, look, the difference between the two figures. Not eradicated, 4 and 10,000 and 100,000. Eradicated, less than 1. So 3/4 reduction in the incidence of cancer if you were to be treated with H. pylori. And even after the treatment of the cancer, right, if you were to treat them, so the likelihood of what they refer to as metachronous, that is development of another cancer in a patient who had already developed cancer, is much less. So if you treat, you reduce the chances of cancer. Here is a reference from Taiwan. They employed mass population eradication over a fairly long time, about 14 years. Look at the reduction of the incidence of H. pylori, right? Accordingly, there is a reduction in the incidence of gastric carcinoma, as well as death from the gastric cancer. Significant reduction if you compare the predicted as well as the actual observed reduction. Okay, well, that is, knowing that is the case, fairly in United Arab Emirates, it's a high virulence. The disease is prevalent. It can be associated with significant disease. It deserves to be treated. Are we treated in the right way? Are we treating it in the right way? Well, we have to look at that. Recently, we were guided by international consensus and guidelines. That was the initial one, the agreement between NASPGHAN and SPGHAN, superseded by another one a few years later, right? The interesting fact, out of those, we were supposed not to treat unless there is symptoms. Don't look for test and treat. Treat only if there is significant dyspeptic symptoms. And up to now, that's what we're doing, I believe, most of us. Now, the major change came in 2015, Kyoto Consensus declared H. pylori as infectious disease, right? As an infectious disease. And that carries a meaning. Now, this was taken into account in a recent publication by, the Maastricht 6, the 6th Maastricht Consensus, right? They took that into account, and that produced the major change, which I believe is going to make significant change in the way we will be managing H. pylori, really. Taking into account that, no, it is now an infectious disease. It is not a commensal. It's actually a pathogen, right? So they took that into account. One of the major recommendations that, so gastritis is there, irrespective of the symptoms. That cannot be ignored. Inflammation is there, even if you're not symptomatic. Not just that. They gave it, the ICD code. So accordingly, that has to be treated. A disease, you cannot really ignore it. And here, major shift, test and treat. Previously, they say, well, no, don't test and treat among dyspeptic symptom, not just among dyspeptic symptom, even actually population-based treatment. Screen everybody, treat those who are positive. But where? In areas where the incidence is intermediate to high. this is still, something need to be fine-tuned. So eradications offers prevention against gastric cancer. We saw the evidence. They were right in saying that. But if you were to do that, you have to do it early on, before the development of atrophic gastritis. We know that the acquisition of disease is early on in childhood, and they were recommending, that such screening has to be incorporated into national programs, and perhaps you can actually use the current available one, like the screening for gastric cancer and so forth. At the same time, you screen for H. pylori and treat. Why not? And not just that, it is actually found to be cost effective. Yeah, it is cost effective. You may actually argue, say, well, why do you need to treat, the whole population to prevent 3%? It is cost effective in high and intermediate incidence area. They were referring to that you might actually need to screen or identify those patients or those group of people among the community who are at higher risk. And interestingly enough, after the publication of this consensus in August last year, just last month, there was a publication identifying 9 gene variants among some patients. If they were to be infected with H. pylori, they develop a risk of developing gastric cancer of almost 50% compared to those who do not have that variant. So this might limit the number of people you need to treat. This might limit the complications of mass antibiotic treatment. Right? This may actually in the future will be taken into account. So we are obliged to treat this infection, knowing how serious it can be in our area, how common it is, and the seriousness of the associated complications, and the evidence that if you were to eradicate it, you reduce the risk. But whatever you use in terms of therapy, it has to be effective. It has to achieve more than 90% effective eradication. And for that, you were supposed to actually identify the antibiotic susceptibility, right? And the local resistance of the organism. Well, there isn't much references at the moment published locally here to identify the effectiveness of the first-line medications and so forth. So we try to sort of do a bit of work, and we have started already. Dr. Iman, one of our fellows at the moment, already enrolled 150 patients looking at the effectiveness of the local first-line regimes in eradicating. And hopefully, inshallah, within 4 to 6 months, we will have some results to put through to you. But unfortunately, I think the local effectiveness or the effectiveness of local regimes is really low. I could not find an actual figure to refer to or a reference. But there are certain issues. If the effectiveness is low, the problem can be in the bacteria therapy issue and patient related. So antibiotic resistance, major problem all over the world, and that is the main reason behind failure of antibiotic treatment is the antibiotic resistance to clarithromycin, metronidazole, and levofloxacin. The 3 main antibiotics. There is very high resistance among them all over the world. Look, even more than 50% in the dark red areas. Well, look at the Middle East here, one of the most commonly affected area with high resistance, and most likely to do with the indiscriminate use of antibiotics. This is, and again, some reference from America and Europe. They looked at the resistance of culture-proven bacteria from the 2 different regions, and they found clarithromycin 0.25% resistance, almost 2/3 metronidazole. Yet amoxicillin is very low, right? And that is an important fact. Amoxicillin is very low. The others are very common. So clarithromycin and metronidazole. So out of this paper here, they say clarithromycin-based one should be abandoned. not to be used, right? Do not use clarithromycin-based one. What we're doing at the moment in our area, certainly those I'm aware of, but I believe everywhere else, that is still clarithromycin-based. Major evidence, systematic reviews, pointing towards the same thing. High incidence of clarithromycin, metronidazole, low incidence of resistance, amoxicillin and tetracycline, really 1 to 4%. In United Arab Emirates, the only reference is from those groups, El Farsi and El Tayyari from Zaid Military Hospital. 55 in one group, 22 in another group, using the genome sequencing and PCR. So the 2/3 are resistant to clarithromycin. They're here, 1/3 there, and less with the 1/5. So still very high, right? To metronidazole, according to this, it's just 10%. Accordingly, the Maastricht, the 6th Maastricht is recommending that we should identify and find out the susceptibility of the local of the organism in the local area, using either culture-based or PCR. And what they were recommending in areas where the incidence of resistance is more than 15%, and that is the figure. If the incidence of the resistance is more than 15%, the antibiotic is obsolete. Don't use it, right? So they say if the actual incidence of resistance is known more than 15%, don't use clarithromycin-based, and don't use triple therapy. Use quadruple therapy. If you don't know, which is basically the case here, use quadruple therapy, really, right? So bismuth-based or non-bismuth-based, amoxicillin, clarithromycin, metronidazole, and a PPI, and for 2 weeks, right? So yeah, it has to achieve more than 90%. How to test for the antimicrobial susceptibility? You can test for these antibiotics either by culture or by genome sequencing, and be aware between the difference between rifampicin and rifabutin. Rifabutin is one of the new antibiotics on asking, and they recommend PCR either for identifying the actual infection in the culture or in the biopsy specimens, or identifying the mutated genes in the bacteria. And whether to test from gastric specimen or from stool itself, that is important. Easier way to do is actually detect the organism in the stool and test the sensitivity using PCR. There's no difference in the sensitivity and the specificity, you know. So the recommendation is bismuth quadruple therapy, right, by all the different consensus. So the non-bismuth based is the second one. Again, if bismuth is not available, PPI triple only if you know the culture and sensitivity. The recommendation, clarithromycin based, is obsolete. Don't use it. If you don't know the sensitivity, don't use clarithromycin. And definitely it's much higher than anywhere else, much higher than 15%. So what do you use? Use bismuth based if it is available, or quadruple non-bismuth based.
Okay, Dr. Amer, we have 2 minutes to
Inshallah.
carry on.
Inshallah. Yeah. After you treat, you're supposed to check eradication. It's not just treat and go. No, come back. Unfortunately, that does not happen that often. In United Arab Emirates, only 30% of patients come back to have their assessment checked. Unfortunately, even after identifying the susceptibility and treating the patient with the right antibiotics, you may not achieve good eradication because of other factors. See, 50% treated according to susceptibility, 50% succeeded in eradicating the infection, other 50 not, because of other factors. These other factors you have to identify. The most important is effective pH reduction in the stomach. You know, the antibiotics will work better if you effectively reduce the pH, right? For certain reasons. PPIs sort of improve the growth of bacteria. So if the bacteria is actively growing, becomes more susceptible to antibiotic effect. Along with the sort of the PBIs, so to increase the concentration of the antibiotic inside the bacterial cells. So double dose therapy is better than single dose therapy. So if you were to use PBIs twice daily rather than once daily. You also need to consider that some people are high metabolizer of the PBI compared to others. And very, among different populations, high, different incidence of the high metabolization. See, but even among high metabolizers, if you were to use the twice daily, you achieve better drug therapy level. So use twice daily PBI rather than single daily. New development is a different, is a new PBI, is a new anti-secretory medication, vonoprazole, potassium blocker. On compared to the traditional triple therapies, even same or better. Twice, with double therapy or triple therapy. Esomeprazole is better than the traditional second generation ones. See, if compared to omeprazole, is almost 30% more effective. The vonoprazan is almost 3 times more effective than the traditional omeprazole. So the higher control of pH, the better eradication. Okay. Key concepts. And this is the message which I want to pass through, really. To not use clarithromycin-based therapy. Instead, use bismuth or non-bismuth quadruple therapy. We should advocate for assessment of sensitivity. I think culture may not be the easiest. Instead, PCR-related methods is much easier. Nowadays, programs are there, automated. It doesn't take much. It may not be available everywhere, but we should really keep it in mind. Vonoprazole therapy will come into the market. And thank you very much.